I'm going to discuss type B heart failure, that is an asymptomatic heart failure. And before that, I must tell you what all parameter you need to describe when you are describing a patient of a heart failure. The first most parameter would be to understand that heart failure is just not ejection fraction fall or pedal edema or dyspnea. It's a syndrome. It's a syndrome involving number of organs in the body, which includes the muscle fibers, which are converted from type 1 to type 2, which are more oxygen demanding. There are a lot of other changes happen in the muscle apart from that. Neurohormonal changes, we all know that there is an adrenergic activity, there is increase in inflammatory changes there. Then there are a lot of things happen in the cardiorenal axis, or what we call as the cardiorenal syndrome, to the tune that new terminology is kind of being described in the way that there could be something like renal tamponade. It means that once you have a venous congestion of an acute origin, when you have a renal fascia which is kind of as stiff as pericardium, so this causes a restriction of the dimension increase of the kidneys. So once you have an acute renal congestion, increase in volume of the kidneys, then it leads to a kind of a tamponade situation, reducing its perfusion. There are so many other factors which are kidney cardiac related, which are important. We can have protein losing enteropathies in patients with more of a right-sided failure or a constrictive pericarditis like of situation. Here you lose proteins or albumin through the gut, and there is an hypoalbuminemia, and then there are a lot of inflammatory things happening in the body. Simply fluid overload is considered as an inflammatory disorder. So it's a syndrome, not a disease. Two is that once you have a fall in ejection fraction, you should know whether this ejection fraction falls in which category. We have a mild LV systolic dysfunction, we have a moderate and a severe LV systolic dysfunction based on ejection fraction. So these are the two things. Third one is that you can stage the heart failure in stage A being once you have risk factors for heart disease. B is that once you have an asymptomatic heart failure, these days we have included the fall of global longitudinal strain also as a marker of a LV dysfunction. Then we categorize this patient in type B. Let's say if there is a patient of diabetes has a reduced GLS, that would not be category A, that would be category or a stage B. So stage B is reduced ejection fraction or diastolic dysfunctions or a reduced GLS, and patient is not symptomatic. Stage C is a symptomatic heart failure, you and me say day in day out in clinical practice, and D is kind of a severe heart failure requiring multiple hospitalizations. So stage 1, where you have a lot of risk factors to develop heart failure, hypertension, diabetes, CKD and obesity and many more are precursors for heart failure, and we need to act here before the heart failure appears. So now this is not a very uncommon kind of situation that you have hypertension or diabetic in a patient who is about 60 or 70 years old, is obese and has a mild albuminuria or in bit elevation of creatinine. So all these things put together makes it a very high likelihood of a person to develop heart failure in future. These are the patients where we have certain screening protocols I'm going to describe. So if these screening protocols show you some risk of heart failure, then it's a good idea to get an echocardiogram, and that too a detailed one where we not only do ejection fraction, we do global longitudinal strain of LV and LA and RV as well as LA volumes. Just a concept. Now let's talk about women with various kind of malignancies, and that's the outcome of CA breast, that's an outcome of myocardial infarction, CA colon, ovary, and that's a CA lung with the severe one. Where does the heart failure fit in? heart failure has a higher mortality or chance of dying than more than most of the malignancies the women would have. And the situation isn't different in men. Here also, heart failure is more unsafe than, let's say, CA prostate or CA bladder. So, I mean, the concept which I want to tell you is that once you have a person who has a high risk of carcinoma of breast, what do we do as a screening in the general public is that we do a mammography. For a CA colon, we do colonoscopy, and for CA prostate, we do certain blood biochemistry. What do we do for heart failure, which has almost the same outcome? We do nothing. Let's start doing something there. We can do better by screening these group of patients, and we should pick up from stage A category, that patient those who are at risk of developing heart failure, and pick up those who have stage B heart failure, those who have markers for heart failure. So how do we do that? So its idea is to pick up subclinical stage so that it doesn't go to the clinical form. Is it really uncommon to have that? Surprisingly, it is 4 times as common as C and D stages put together. That means asymptomatic heart failure is far more prevalent than a symptomatic or severely symptomatic heart failure. Why we are not seeing it? Because we are not actually looking for it. So let's say if we have a patient with a stage A, we want to prevent this patient to develop into stage B or asymptomatic heart failure, we must have an appropriate drug therapy. It preferred to be an AC inhibitor, then SGLT2 in a patient of a diabetic, and we must optimize the therapy for cardiovascular risks. And then there is an important issue that you should actually screen these patients with natriuretic peptide and other things so that you do not miss a stage B heart failure. If I tell you about the prognosis, look at the prognosis of the patients, those who had no heart failure or any asymptomatic, and these are asymptomatic, mild and mild to moderate severe heart failure. As compared to symptomatic, the mortality figures are actually quite high. Ejection fraction is kind of tough these days to most of the ejection fractions done on a 2D or an M mode, they fall a fallacy that there are a lot of geometric assumptions what we take, and if you compare head on with the MRI, that actually does not correlate too well. And what correlates well with the MRI is a three-dimensional echo. We had a tough time in the past of tracking the margins, and calculating ejection fraction used to take long time. With the advancement technology, we can do that in less than 15 seconds, and by that we get all LA, LV volumes, including the ejection fraction and LV mass as well. So this is probably more quicker method than the Simpson method to calculate ejection fraction, and far more accurate, as the 3D echo correlates very well with the CMR. Now we have patients for symptomatic heart failure, we day in day out treat in our clinical practice. Certainly we would wish to look at patients those who have an asymptomatic heart failure and that ejection fraction is lower and they are not symptomatic. But I think I am going to shift my focus little down further, that we want to pick up the patients those who are a higher risk of developing heart failure, even asymptomatic. So what are these populations? They are a high risk population. Then these are the population we must look for the screening things. These are hypertension, diabetes, CKD, obesity, and valvular heart disease. Probably account for 20% of our cardiology day-to-day or medicine practice. So how do we do it? We do two markers. One is NTpBNP, and the second is a high sensitivity troponin. And any of them, if it is elevated, calls for a further investigation, which is an echocardiogram. And is it uncommon? Not really. The elevated NTpBNP, if you look at, accounts for about 25% of the patients, those who have, and this is elevation is pretty common in patients with diabetes. So whenever you have this kind of situation, good idea to go ahead with echocardiography and find out other parameters. Now, our interest is to find out a subclinical heart failure, and can we detect subclinical heart failure before ejection fraction fall? That's a new concept and era. Now, we have myocardial fibers which are arranged in these two fashions. The endocardial fibers are actually longitudinal fibers placed in the longitudinal direction, while the circumferential or outer ones are in the circular fashion. So, what does it actually translate into? That is the LV contraction, and you see there is a dimension change, there is a thickening or a circular shortening, there is a shortening of the length, and there is actually rotation, and that is a twist which is produced, and these all put together they contribute to ejection fraction. If I may say, the rotation contributes to about 30%, and the circumferential produces another 30% and 40% by longitudinal shortening. So what happens whenever you have a pathology, whether it's a myocarditis, whether it's a diabetes, whether it's an amyloidosis, or whether it's an ischemic insult, because of the presence away from the coronary watershed area, if the coronary watershed area is an endocardium and the longitudinal fibers are earliest to get affected in any kind of pathology, then is the circumferential and then the helical fibers, because they are lying outside towards the epicardium. So that is the way the most of the diseases of the heart get affected. And early myocardial damage, you get what? You get a reduction in longitudinal contraction, and that is actually compensated by circumferential contraction and the twist. And then there is a reduction in the LV size and left ventricular hypertrophy, that these also are compensatory mechanisms for fall in longitudinal contraction or early myocardial systolic dysfunction. And then what happens? The ejection fraction is maintained by these compensatory mechanisms. I am going to show you a case. This is a patient with hypertrophic cardiomyopathy, and you might say the ejection fraction is kind of supernormal. It's elevated, it's increased. Now, do you see this? But do you think that there is a systolic dysfunction with an ejection fraction being supernormal? Quite possible. Reason being the longitudinal the fibers are affected, and these are the circular fibers. Look at the twist. Now this twist, this is the apical short axis view. Look at the twist which is being exaggerated, and this is kind of compensated for loss of a longitudinal contraction. So once the longitudinal fibers are involved, further down the line in the myocardial damage sequelae, there is a circumferential fiber involvement. In fact, all card muscles are affected, and that's the time when ejection fraction falls. So if I am able to pick up the longitudinal contraction and there is a reduction or fall, I would be able to pick up the disease before the ejection fraction falls. That's the concept. So we have patient with the subclinical LV ejection fraction does not fall, then there is a systolic dysfunction, but ejection fraction fall takes time. So I want to pick up the disease in this stage when there is not a fall in ejection fraction, but there is a reduction in longitudinal contraction only. How do we do that? We do it with the global longitudinal strain, and that's not a research tool anymore. We use it day in, day out in our clinical practice. How do we do it? We can see this is something like a face recognition software, where the face is recognized despite a lot of clutter around. The face is still recognized. This is how our equipments recognize the speckles and the movement of speckle during the phases of ejection. Then we calculate the longitudinal contraction based on that. So now with the universal definition and classification of stage B heart failure, reduced global longitudinal strain is considered as an equivalent of a fall in ejection fraction. But is it really difficult to calculate GLS? But if I tell you the GLS is easier to calculate than ejection fraction because of human error in calculating ejection fraction, while GLS is automated by the equipment, is far more consistent inter observer variability. The paradigm shift actually happened when we had a patient on anthracycline, doxorubicin in CA breast and CA lung, and when we used this, we found a couple of patients had a fall because of the cardiotoxicity, fall in ejection fraction. That is the time when we stopped this drug, but unfortunately 50% of them continued to have fall in ejection fraction and did not improve even after stopping. So that means we were late when we were picking up systolic functions. If I pick up systolic function at the stage when ejection fraction has started falling, I think we am getting late. So what shift happened? We picked up at the GLS level, fall in GLS. We started ACE inhibitor and a beta blocker, and maybe continued with a reduced dose of the same drug, did not discontinue, and GLS improved, ejection fraction did not fall. So then we said, okay, it's a good idea to pick up the diseases of myocardial systolic dysfunction early enough so that before the ejection fraction falls. So if we wait till the ejection fraction falls, I think we get late. So diabetes, let me discuss the first condition for a subclinical heart failure. Diabetes has a very high risk of heart failure development apart from atherosclerotic vascular disease, renal disorders and eye involvement. But heart failure as a complication of diabetes, many a times we actually forget or ignore as one of the complications. And in patients, those who have diabetes, look at the figure of elevated at the biomarkers for heart failure. They are markedly elevated to the tune that in about 30% of the patients you get these elevated markers. Okay, so but I can tell you that 1/3 patients of diabetes have a subclinical heart failure. That is a huge number, and they don't do well against the normal LV systolic function. Their outcome is worse in future. And then there was one study which showed that global longitudinal strain less than 18 was present in about 35 to 40% of the patients, a huge number. So now this is a large meta-analysis giving an assessment of speckle tracking and echocardiogram in patients those who had diabetes, and look, then there is a fall in a GLS indicating systolic dysfunction. There was a fall in LA global longitudinal strain, and there was fall in the RV global strain. If I may tell you which one was the winner out of this, LA. Yes, if you have an LA strain, this was the worst outcome group of patients. So we have these pillars of heart failure, with heart failure with reduced ejection fraction, and we are all well aware about these pillars. And are these same drugs are applicable in heart failure with asymptomatic situation? Do we have a reduced ejection fraction, but patient is asymptomatic, that is stage B heart failure? That's true, they might be effective, but as of now we have a data on a AC inhibitors and a beta blocker, and there are some studies showing a change in the SGLT2 inhibitors. For MRA and for RNE, we still don't have data whether they are as effective in asymptomatic heart failure. So I think that would be a good idea now to sum up, to say that subclinical heart failure is far more common than we think. Its screening is required for almost all high risk group of patients which currently we are not following. Then reduced ejection fraction with reduced GLS are both actually important if you find on an echo to say that this is stage B heart failure. And in case you do find the early stage heart failure, you start doing an AC inhibitor and beta blockers. And I think it's a good idea to subscribe the channel so that I am going to continue on this journey of education and knowledge sharing. And whenever I post something new, you would get notified. Happy learning.